Guys, so we're going to continue our lecture on esophageal disorder, and in this lecture we will be focusing on the esophageal motility and obstruction disorder. And first disorder that I'm going to talk here is achalasia. That's what I'm going to talk about. All right, let me just write down here this disorder. This is what is called achalasia, and I just want to mention this. What is this achalasia means? Just think about this is basically a condition in which there is the failure. Let's just write down here the failure of lower esophageal sphincter to relax. All right, so whenever we talk about the achalasia, it basically means somehow there's a pathology, and we're going to talk about this, that this lower esophageal sphincter, which is like down here, which is not anatomical but more physiological sphincter right here, let's just say this part, somehow this is not relaxing, and when that happens, that result into increasing this lower esophageal, let's say this pressure, or let's say tone, all right? And basically what happens, if there's increase in lower esophageal sphincter pressure, or let's say there's an increase in intraesophageal pressure, that basically causes aperistalsis. And what is peristalsis means? Basically means that the segmental contractions in which that whenever we take the food, let's say for example, if the food is here, right, the food has to move down to this tube, this food pipe, to the stomach here. And if there is no peristalsis, that means the movement of the food would not happen. So in that case, we call them aperistalsis. And just remember this. I do have to tell you that with this achalasia, there are different nomenclatures or different names are given, all right? And some of the names, I'll mention it to you. This achalasia, they can also call this as a achalasia cardiae, all right? Because it is within the cardiac cavity, so that's the reason why we call them a cardiae. And sometimes, they even refer this as you have esophageal aperistalsis. There is another name for this one. And sometimes they also call them as a esophageal spasm, which basically means that there is some sort of a spasm is here that result into that this lower esophageal sphincter, which is more physiological, it's not able to relax, so that way it causes the food to accumulate in these conditions, achalasia. And achalasia, usually it is relatively uncommon, about at least in US, you can expect to get like maybe 10 cases per 100,000 populations or people. All right, it's relatively uncommon. Now, we have to talk about, this achalasia. What is the pathophysiology behind these conditions? Okay, so basically, the primary reason, so let's say we can say this primary achalasia, all right, it basically is primary achalasia has uncertain, let's just say uncertain or unclear basically causes. We do not know exactly what causes these conditions. There has been studies that have shown that maybe this could be due to pre-exposed to the virus, maybe from the herpes viruses, or could be from measles, but this has been hypothesized, but obviously it hasn't been proven. All right, and we also have to talk about the whole concept of the secondary. There's also another called secondary achalasia is there too. All right, and we'll talk about this is now. So what exactly happened in this condition? So basically, one of the most important things you have to remember here is that, let's go to talk about what I drew here. So you guys know this is a trachea right here, which divides into left and right bronchus, and this is the lungs. And this is going to be my right here is my esophagus, all right? Now, if you remember, we talked about in the histology aspect of the esophagus that, there is a line, there's a mucosa lining, all right? There's a mucosa lining. There are four lining. You have a mucosa, right? And then you have a submucosa, right? You have a submucosa, and then you have a muscularis externa, and then you have adventitia, right? And then usually in the muscularis externa, there is a network of this plexus. What is this plexus is called? You have to remember, this is a very important plexus because within this muscularis externa, there's two layers of the muscle that you find, and one of the important layers, this muscle is what is called, you have a circular muscle, which is usually inner, and then this is a outer or longitudinal. Okay, this is a longitudinal muscles. All right, and between the circular and this longitudinal muscles, what happens is there is a network of this plexus, and this network of this plexus, we call them there's two names are given for this one. This is an autonomic nervous systems of the gut, and we call them you can say this is you have a myenteric, or they also call this as a Iow-Bag plexus. All right, the basic this let's just say this is Iow-Bag. So you have Iow-Bag plexus. So this network of this myenteric plexus are they are autonomic nervous systems of the GI tract. Right now we're focusing on the esophagus, so we'll say that this is an autonomic nervous systems of the esophagus, right? And this autonomic, it has these networks are composed of ascending neurons and descending neurons, and I'll make this very easy for you. So you see this right here, this one, if you follow this, we can make that, this is maybe going to the, let's say, aboral side, all right? And this is let's say this is a descending neurons, all right? And these descending neurons are inhibitory in nature. And this one, which is going to the oral side, let's just write down here, and we can say this one is more stimulatory, or you can even say this as excitatory neurons. All right, so this is something that you have to remember, and both of them are composed of what? They're composed of these, and both of them we call them these are the myenteric plexus of the GI tract. All right, now, so one of the most important things happens is that whenever in a normal physiology, let's say this is a food particles, or whenever the food comes in, basically what needs to happen is there should not be any obstruction to the esophagus. And other thing is that there has to be normal peristalsis. There's normal movement of the food, okay? Normal segmental relaxation, segmental contractions and relaxation. So if this is a food, this is above this food, we call this a proximal portion, right? And below the food, we call them a distal. So this proximal esophagus, there has to be contractions, and then this food, the distal to the food, there has to be relaxations, okay? So that's how the food should able to move. But if there's any sort of any sort of problems associated within this, then we can get a condition called achalasia, specifically if there is a problems with the inhibitory neurons, all right? So now, what basically happens here is that if you follow this, look, in these conditions, the way it works is that if you look at this sphincter right here, this is, let's say, lower esophageal sphincter, right? And usually what happens is that when the food comes right here, this guy's right here, look, if I follow this should be, let's say for example, now my food is here, let's say my food is here. And if my food is there, that means there has to be this thing right here, right? This thing has to do, so right here, it has to release a neurotransmitter, okay, that has to be, stimulatory in nature. And then there has to be this right here with the green, which is, sorry actually, made a mistake down here. This is right here, is a boral side. So this guy's right has to be inhibitory, and this has to be stimulatory, right? Remember, when the food comes here, basically what happens usually is that whenever the food comes in here, that causes stretch, or that causes stretch, and then they're sensed by the sensory nerves, and they'll bring the sensory information to this minatory plexus, right? And when they bring the minatory plexus, these guys will sense by the ascending and descending neurons, and they'll respond based on that. So if they respond by, let's say, there's ascending neurons which are excitatory in nature, which is this one in green, what they do, they will stimulate this right here, and they'll do positive stimulation, meaning that they will release, very importantly, acetylcholine, substance P. That's what they release, right? And sometimes, like, histamine, these guys are there too, and or even prostaglandins, let's say prostaglandins F2 alpha, or let's say motility, all right? These are all stimulatory in nature, all right? And basically what they do is that, they will cause this muscle, the circular muscle cells, muscle cells will contract. And when the circular muscle cell contract, that causes, look, this lumen. So that way, it causes, basically, contracts it down here, the food will move downward. But in order for the food to move downward, there is also this inhibitory neurons by this one, which is the descending neurons. They will release, basically, very, very important concept. Like, let me just write down here, because this is very important. They will release, which are inhibitory neurons, they will release VIP and then nitric oxide. And that causes a relaxation, okay? That causes the relaxation to the distal esophagus, and then that's how the food moves, all right? Down to the stomach. Now, the problem with this achalasia is that we've been saying that the failure of relaxations of the lower esophageal sphincter. And the reason why that happens is that this inhibitory neurons, right here, right? These inhibitory neurons, what happens is that due to some unknown cause, all right, what happens is that causes a chronic inflammation or chronic irritation to the cells, the nerve cells, right? The ganglion cells. Let's write it down. Let's say here, the chronic, or progressive, let's just say chronic inflammations of this ganglion cells, right? Ganglion cells, which are inhibitory in nature, right? Inhibitory neurons, right? So chronic inflammations are chronic irritations of the ganglion cell, which causes these inhibitory neurons to produce what? If there's inflammation in there and there's a chronic irritation, that can result into productions of nitric oxide, and VIP will be reduced. So basically, what is happening here? There's a progressive degenerations. Let's write down here. There's a progressive degenerations of this myenteric plexus, okay? Progressive degeneration of myenteric plexus, all due to chronic irritations or inflammations of ganglion cells, which are inhibitory neurons. And over the time, what happens is that could result into loss of the number of these ganglion cells, right? And that could result into decreased level of VIP and nitric oxide. Again, I'm writing it down because this is very important. Because if you have a decreased level of VIP and nitric oxide, that means that this would not be able to relax, right? This would not be able to relax. And what happens is that these guys, these excitatory neurons, what happened? Because they want this lower esophageal sphincter to close, right? In that case, what happens is you see basically increased level of maybe gastrin there, okay? What else? Like, we say prostaglandins, F2 alpha, acetylcholine, we talked about substance P. Okay, some of the endocrine, like polypeptides, you can see that, all right? Endocrine polypeptides and histamine, right? Motility, all of them causes what happened? All of them causes increase in lower esophageal sphincter tone, which in turn causes increase in lower esophageal sphincter pressure, which is right down here, okay? And when that happens, look, basically what happens, the distal part of the esophagus is not relaxing, so food is not coming, so the food is started getting accumulating here, right? When the food started getting accumulating right here, what happens? This part of the esophagus, right? This part, they will get what? They will get, let's just make this as, and I'll make it the red, they'll get dilated now. Look at this. So they'll get, this all food is accumulating now here, okay? So now your proximal part of the esophagus will be dilated, and then distal part of the esophagus will make this in a here, different color, will be, looks like this. So this is how it looks like. So if you see this right here, let me make this as this one. There's a stomach right here, okay? So now this is stenosis right here, look. This is a distal esophagus because it's not relaxing, right? So that means that the because the food's going to get accumulated, that causes the stretch, right? And the dilated proximal esophagus, and then distal, you see this stenosis sort of thing, okay? The distal stenosis you see. So basically, now let's just quickly repeat. Again, achalasia was a different names. Esophageal or peristalsis happens. It's a motility disorder. Basically, what happens is that whenever there is a progressive, it is by the way, it is a progressive degeneration conditions, which of the mesenteric plexus, which causes basically the chronic, which causes the, and that is because of the due to chronic inflammations of ganglion cells, and that which produces like VIP and nitric oxide. Those level of nitric oxide and VIP is reduced. When that happens, that can, if the nitric oxide and VIP is low, which is a VIP is vasoactive intestinal peptide, that means there will not be relaxation distal to the food. So in that case, what happens? The food is going to get accumulate above the proximal esophagus, and over the times what happens is that this proximal esophagus will start dilating, right? And you see stenosis on the lower esophageal sphincter. So basically what is really happening here is that this could result into increase in what? This intraesophageal pressure. Now remember, the food tried to come here, there's a lot of contraction happening, but the food is not going. So food is accumulating down here, right? So that's why you see increase in this lower esophageal sphincter pressure there, right? Or even you can see the intraesophageal pressure goes up, right? Now, when this happens, let's say when the food is gonna get started accumulating down here, what is that gonna happen to the patient? Remember, if the food getting accumulated here, the food is not going down to the stomach. That means food is gonna get accumulated, and what are some of the conditions that can happen if the food is gonna get accumulated here? Look at this. Let's write me down the symptoms here. If the food is getting accumulated down here, obviously when people try to eat, they'll have difficult swallowing. So dysphagia is very, very common with these people. And then not only this, so this food did not able to go to the stomach, so they did not participate in digestion process. So this food can actually regurgitate backwards. It can come backward. Remember, it can cause regurgitations. And what does regurgitation basically means? Which basically means that, that the undigested food is coming back. It can cause that. And because the food is accumulating here, around there is the thoracic cavity, right? The thoracic cavity. So because of the stretch, that can cause stress to the thoracic wall, and that can result into chest pain too. So these are some of the classical signs of this. And remember, you You have this dysphagia, regurgitation, chest pain, and what is happening here is that over the times, this food can come back to down to the mouth, and it can also give you bad smells, okay? Halitosis can happen. And then the most important things I have to mention to you is that, you know, if you look at it here, when the food is coming here, because there's a stenosis is right here, right? Look at this. In that case, what happens is this will result into not only the food, solid food, but also the liquid food dysphagia. So even the liquid cannot pass through this, right? So the achalasia is a conditions where solid and liquid, both of them would not able to pass through this, okay? So this is something that you have to remember. Now, you know, but remember this, you know, if you know this achalasia, but there are other conditions that can give you similar signs and symptoms as achalasia. And you have to remember some of the classical ones, which is, let me write it down here. Actually, let me write it down here. Which are the secondary type of this achalasia, all right? And that is due to, all right, this disease called Chagas disease, all right? And this is usually has to do with this parasites. This parasite's name, what is the name of the parasite? You have a Trypanosoma cruzi. These parasites, the Chagas disease, this can also give you this achalasia, all right? But these are usually like secondary type of achalasia, and usually these are commonly seen in more developing countries, like more like in South America, not usually common in let's say US. But not only that, the other condition like, you know, paraneoplastic disorders of lungs, that can also give you conditions like achalasia. So this is why it is important to rule out that the primary or the secondary achalasia, all right? Now, one of the things that I do have to mention here is that the concept of the scleroderma too. And this is another condition which is also scleroderma. It is a connective tissue disorder. This can also give you a sort of like, you know, dysphagia, regurgitation, chest-like pain, and chest pains, all the symptoms that can actually match achalasia. But in the scleroderma, one thing that can happen is that if you need to do differential diagnosis, one of the things is that you need to look at these pressures of a lower esophageal pressure through the manometry. And if you do the manometry lower esophageal pressure, usually with the scleroderma, this lower esophageal pressure is decreased. This is very important, okay? And how do you distinguish between the achalasia and the scleroderma? Look at the lower esophageal pressure. In the scleroderma, it is lower, but in the achalasia, it's higher, okay? This is one of the important concepts that you have to know about it, all right? And these both are, you know, for this both solid and liquid food. And then how do we know, like how do you do, let's say, you know, what are the diagnostic criteria to, you know, to examine this achalasia? One of the things you could do is something called barium swallow, okay? So when you do a barium swallow, if you do a barium swallow, when you put a barium swallow, like barium, what happens is food will accumulate right here. So let's just say this, it'll look something like this. Look, and this is all, look, it's going to look all white here, right? And there's stenosis. So this type of appearance on the barium swallow, we call them a bird's beak appearance, okay, or rat, something else, you know, they call this as a bird's beak type of appearance, all right, or rat tail appearance. That's also they call this as, okay. So this is how you can actually do the differential diagnosis or the diagnostic criteria to do the differential diagnosis of the achalasia. And you can also do the pressure, the manometry pressure, because usually in the manometry pressure you're going to be able to see that there's an increase in left esophageal pressure, right? But remember, guys, this is about achalasia, right? And there are other disorders, like remember other disorders I talked about, which can give you a, achalasia type of symptoms, and that is one of the very important one with the Chagas disease, which is caused with the parasites Trypanosoma cruzi, and other conditions like paraneoplastic of the lung cancers that can also give you, and then very importantly, more likely test you on the exam is Scleroderma, and which is a connective disorders, and that can also give you all this achalasia like of symptoms. But remember this. But if you want to do how do you distinguish between it is Scleroderma versus this achalasia, you have to look at the lower esophageal pressure, okay? And usually lower esophageal pressure is lower in the Scleroderma. But having said that, these are the three conditions that I talked about. But there are other conditions also you have to rule out before you diagnose the person with achalasia. And there are two other syndromes that I have to talk about. One of the syndromes is right here. Look, we call them. This is called diffuse esophageal syndrome, and the other one is called nutcracker syndromes. Okay, nutcracker actually it's called nutcracker esophagus. All right. And what is the difference between this diffuse esophageal syndromes versus the nutcracker esophageal syndromes and achalasia? What is these three differences? Look, diffuse esophageal syndrome, what is basically happening there is that, in this condition right here, in the diffuse esophageal syndrome, one thing that really happens here is that there is repetitions of, okay, there's a repetitions of what? There's repetitions of this contractions, okay, of the distal esophagus. Okay, so basically there is a repetitions or simultaneous or uncoordinated contractions of this distal esophagus. And when that happens, that happens all over the esophagus, right? Right, basically. And in that case, what happens is that over the times, it will cause something called corkscrew appearance if you do a barium swallow. So it will look something like this. So if I make this esophagus right here, right? Let me make it here. If I make this esophagus right here, usually it will appear like this. And this part right here, this is what is called corkscrew appearance of the esophagus in the diffuse esophageal syndrome. But remember, in the diffuse esophageal syndrome, what is normal is this pressure right here. This lower esophageal pressure is normal. There's a normal, look. Okay, let me write down here, right here. You see a normal, this lower esophageal pressure is there. All right? This is very, very important concept right here. Now, what about this concept of nutcracker esophagus? Nutcracker esophagus is another condition where there is a high amplitude, uncoordinated contractions, obviously uncoordinated contractions. What does that mean? Which basically means that, there's a high amplitude, meaning that about more than 180 millimeters of mercury of the peristaltic happens. Let's say food is there, right? So this peristaltic happens in that high pressures, and which is obviously uncoordinated. But remember, it is not aperistalsis though, because aperistalsis is only achalasia. In both of these conditions, there is a peristalsis. It's the peristalsis are uncoordinated, and one with a high amplitude, which is nutcracker syndromes, but this one, diffuse, is a normal amplitude. Normal amplitude, okay? And this is how you do a differential diagnosis of this, all right? And again, how do we distinguish between all this, achalasia? Remember, there is a there's a failure of lower esophageal sphincter relax, right, which causes the increase in lower esophageal tone, and that results into the higher increase in pressure, and there's no peristalsis. There's aperistalsis is there, right? And in diagnostic tests, you can, if you do the barium swallow, you can see a bird's beak or rat tail appearance, all right? Diffuse esophageal spasm is a problem with the peristalsis. There is a peristalsis, but it's uncoordinated peristalsis to the distal esophagus, but there is a normal amplitude, okay? Amplitude, and if you look at the lower esophageal pressure, they're normal, all right? And if you look at the nutcracker esophagus, which basically means that there is a high amplitude, okay, of the contractions, which is like more than like 100 millimeters of mercury, that's like average. And then there's obviously uncoordinated peristalsis, right? Uncoordinated peristalsis. And really what happens is that, which causes like this, increase in lower esophageal pressure. So this is how, like, you can actually distinguish between the diffuse esophageal syndrome, nutcracker syndromes, and achalasia, and also the scleroderma here, all right? Scleroderma. Remember this. Achalasia is relatively uncommon, as I talked before, and very uncommon, but it's very important to know because more likely they'll test you on the exams, okay? Now, after this, let me quickly talk about two conditions that they could ask in the exams. And the whole concept of this esophageal webs and then esophageal rings. What is the difference between those two? The esophageal webs, look at this. This is the upper esophagus, right? Upper esophagus. Sometimes what happens is that there is upper esophagus, it has some sort of like, this mucosa, and submucosa sort of like protrudes like this, okay? And it doesn't make it makes like let's just make this as like this. And this is more like a semi-circumferential or ledge. This is called a ledge-like appearance. Maybe due to the chronic inflammations or some of the fibrous tissue lines this, and there's a mucosa or submucosa. It's kind of like protrudes inside to the lumen and causes the obstructions, okay? But remember, these are called esophageal webs though. And esophageal webs are usually non-progressive, all right? They're non-progressive. And they are down here, look at this. They're usually associated with the upper esophagus, very important concept. When you see the webs, which are like web-like appearance, ledge-like appearance, these are commonly seen in the upper esophagus, okay? But if I say rings, then we talk about the lower esophageal, okay? And again, the esophagus webs, which is, you see that because maybe the fibrovasculars or connective tissues are layering, and usually these are lined by the squamous mucosa, okay? And that causes the obstruction, usually only with the solid, but not the liquid, okay? And usually in the questions vineyard, usually they say that. And usually, and there's this right here, usually in the gastroesophageal junction, let me make this one here, right? The gastroesophageal junction right here, okay, there's again, with the mucosa and submucosa, it's going to protrude within this lumen right here and cause obstructions to the only solid food, like only solid, this one is only solid, okay? And this is what is called, you have a Schatzki ring, or they also call these as esophageal rings, all right? And what is important here is that this Schatzki ring or esophageal rings, these are usually happens at the level of gastroesophageal junctions, okay, lower esophageal, like the lower esophageal sphincter, all right, and this is only happens to the solid food, not to the liquid. And most important thing is that one thing that you have to remember is that this is causing obviously obstruction to the solid food, as I said. So obviously that can result into dysphagia, like difficult swallowing. This can result into also difficult swallowing and all. One of the most important things is that, but what could cause this Schatzki ring? Okay, usually sometimes the chronic irritations or reflux esophagitis. What does that mean? Meaning that some kind of acid content is kind of like coming backward, and that causes irritations. And sometimes what happens is that mucosa and submucosa can actually come within that, and that can cause this, okay? And usually if you look at this microscopically, remember, this is very important concept you have to remember. Usually you see microscopically, you see a basically focal, let's write down here, focal circumferential. Look, this is circumferential narrowing at the at the gastroesophageal junctions. Remember, the webs are not circumferential, they're semi-circumferential. They're ledge-like appearance that you see in the lower esophageal, that you see that in upper esophageal. These webs are. The rings or Schatzki rings you see in the lower esophageal sphincter. All right?